Good afternoon, everyone. I'm excited to present you my 3 months progress in the topic of novel approaches in treating pancreatic ductal adenocarcinoma. My name is Melinda Piri. I'm a clinical oncology resident in Szombathely and a PhD student. In my vision, one day pancreatic ductal adenocarcinoma will become a curable, but at least a chronic disease. And to achieve this, my mission is to find treatment options, novel treatment options, to enhance the survival rates of PDAC patients. I have 2 specific goals throughout my PhD. The first one focuses on a special population of patients, oligometastatic PDAC patients, and the treatment options of them. And in the second project, we will try to find the role and place of targeted therapies in the treatment of advanced PDAC patients. So why I think it is a must to conduct research in the topic of pancreatic cancer. It is the 3rd leading cause of cancer-related death in the United States, and it is predicted to be the first in a few years. More than 90% of pancreatic cancers are pancreatic ductal adenocarcinomas, and the incidence of PDAC is rising worldwide. And unfortunately, it often remains asymptomatic, therefore more than 80% of the patients present with an advanced stage disease, therefore they are not anymore eligible for a curative intent surgery. So in my first project, evaluating the effect of multimodal treatments in oligometastatic PDAC patients, we are focusing on patients with a limited metastatic disease. Lately, similarly to other types of cancers, oligometastatic disease have been introduced as an intermediate state between localized and polymetastatic disease in the case of PDAC as well. We are talking about oligometastatic disease when there is a limited number of metastases present at a limited number of sites. They can either occur synchronously at the time of the diagnosis or metachronously after the definitive treatment of the primary tumor. And you might ask, what's the point? Aren't every metastatic disease the same by nature? Based on the branched evolution of tumors, which says that the tumors are heterogeneous and there are distinct subpopulations evolving next to each other parallelly, and these subpopulations have their own clonal drivers which either be weak or if they are stronger, they interfere with each other. Therefore, there is a time period where the tumor mass has a reduced metastatic efficiency. And in this time period, we might have a chance to treat these patients. Therefore, we believe that oligometastatic patients might benefit from a more aggressive approach from metastasis-directed multimodal treatments. However, the guidelines still do not recognize these patients, and the standard of care currently is systemic chemotherapy for them. Therefore, we would like to investigate the impact of these multimodal treatments on the survival of oligometastatic PDAC patients. We formulated a clinical question the following: do metastasis-directed multimodal treatments provide a better prognosis compared to the standard of care? We use the PICO framework. Our population is oligometastatic PDAC patients who undergo systemic chemotherapy. We have 4 groups of interventions. The first one is surgical removal, radiation therapy, interventional radiology, and the combinations of the 3 with chemotherapy. Our comparator is no additional treatment to chemotherapy, and our primary outcomes are overall survival and progression-free survival. And we hypothesize that multimodal treatments provide a better overall survival and progression-free survival compared to the standard of care. Our clinical and research implications are the same: to improve the survival of these patients. We formulated the following search key, which consists of 3 domains. The first domain and the second one refers to our population, and the third one refers to chemotherapy, as every patient has to go through it. We conducted a systematic search in 3 databases, and we had around 10,000 hits. During the preliminary searches, we did find previous meta-analysis, but they focused on only the surgical approach, and we didn't find any Prospero registration which would be the same as ours. And our search key led us to these key articles with which we passed the feasibility test. They have comparable populations, and they are all multi-center analyses with a big sample size. However, they are all retrospective. In this flowchart, you can see that we started with around 10,000 hits, and after the duplicate removal, we ended up almost 8,000. And after the title and abstract selection, we will have around 150 results, eligible articles. We are done with the title and abstract selection. However, we still have to do our conflict meeting, and we will start the full text selection soon. And jumping to my second project, investigating the effectiveness of targeted therapies in advanced pancreatic ductal adenocarcinoma. As I already mentioned, advanced PDAC is a major health burden, and although chemotherapy is proven to be effective, the survival rates still remain low. And unfortunately, the tumor microenvironment of PDAC is immunosuppressive by nature. Therefore, immunotherapy as a monotherapy seems to fail. Therefore, we need to more specific approach, more specific targets. And with the development of genetics and genomics, now we know that, unfortunately, PDAC has a low mutational burden, actually the lowest among the gastrointestinal cancers. And its molecular profile also driven by KRAS mutations, which are hardly tolerable. As you can see on the table, we have only 2 currently available target molecules based on the NCCN guideline. Therefore, the benefits of targeted therapies in the overall PDAC population are still not well established. Therefore, we would like to investigate the effectiveness of targeted therapies in advanced PDAC patients. We formulated our clinical question the following: do different targeted therapies improve survival compared to the standard of care in advanced PDAC patients? We used the PICO framework again. Our population is advanced PDAC patients, preferably with targetable mutations. Our intervention will be targeted therapy, the comparator no targeted therapy, and the outcomes overall survival and progression-free survival. We hypothesized that targeted therapies improve survival rates in PDAC patients. And our clinical and research implications are the same as before to improve survival rates in these patients. With this preliminary search key, which consists of 3 domains, the first 2 is the population, and the third one is the targeted therapies, we conducted the preliminary searches. It definitely needs improvement. We have a lot of hits, but we have found numerous previous meta-analyses. However, they are at least 8 years old. And there are a lot of new articles since then. And we have found one Prospero registration, which is a network meta-analysis about BRCA mutations. And the search key led us to the following key articles. I only listed here the key articles regarding the homologous DNA repair deficiency, because we plan that we might want to focus on only these mutations. All of them are randomized clinical trials, mainly phase 2 and phase 3 trials I have found already. And as a quick summary, the first project is planned to submit it in September, and the second is in December the next year. And let me finish my presentation with the words of one of the key figures of Apollo project. Research is what I'm doing when I don't know what I'm doing, which words might come reassuring during our learning by doing process. Thank you for your kind attention.
When you want to block cell divisions, right, there are several ways to do it. One is signal 2 blockade, or signal 3, or DNA synthesis, and etc. When you are talking about more specific, use the word more specific treatment, what do you mean by that? As far as I know, or teach us, because that's what you want to do one day.
If I understand you well, I meant by more specific approach that we should find the role of targeted therapies, because they preferably only affect the tumor cells. And that's our goal, that's to have less adverse events and more effectiveness of the treatment.
At this time, there is no specific, as far as I know, there is no specific or selective therapy either. That's why you give drug combinations, right?
Yes.
I just wanted to ask a question about your first product. Thank you for your presentation. When we are comparing different kinds of therapies, we are and with meta-analysis, we are always worried about that that different type of people get different type of treatment based on how healthy they are, how maybe they got surgery, maybe the cancer is not surgically removable or something like that. Do you think that in your research, the different type of people that got different type of treatment are clinically comparable? Because if the healthier patients got a different therapy, that will be the best. They will be the best progression-free survival.
Yeah, you have a very great point. First of all, our goal is not to compare the different treatment modalities, but the combination therapies compared to the chemotherapy-only approach. And unfortunately, we almost only have retrospective studies because it's quite a novel idea to use this oligometastatic hypothesis in the case of pancreatic cancer. In these retrospective studies, that's the main bias that they selected more healthy patients for these interventions. However, with including the interventional radiology and radiotherapy approaches, we might include patients with a more poor performance status in this study.
Thank you.
When you've done your research with regards to the oligometastatic pancreatic cancer, have you come across the expression abscopal effect? Do you think it works in this situation?
Well, I don't have enough experience to say if I believe in it or not, but I came across of the abscopal effect, which, as far as I know, that means that if we are irradiating the primary tumor, the metastasis will also shrink in size.
Congratulations on your presentation. Since you mentioned, I wanted to ask what type of radiotherapy or interventional radiological techniques can be used in this case?
So in the studies, there is a very wide range of both radiotherapy and interventional radiology techniques used. However, we decided to only include the ablative ones. So in the radiotherapy, in case of the radiotherapy, we will only include stereotactic body radiation therapy. And in case of interventional radiology, we will include radiofrequency ablation, microwave ablation, and irreversible electroporation.